morning to everyone.
Yeah, good morning, good afternoon, I will say. Huh?
Good afternoon.
Yeah, looking good, looking good.
Step into my office.
Great, so now I promised our audience now the highlight from this ESCI Training Center opening. And yesterday you showed us some surprises, and I think will happen today again, huh? So, Andrew, maybe you can tell us a little bit about your patient and about your surgery.
Well, this is Nuno, by the way. Nuno, say hi, Nuno. Say hi, just hi.
Hi, Nuno.
This is Nuno. Nuno is short of the lower first molar. He lost the tooth 5 or 6 years ago. You can see on the X-ray on the co-diagnostics that we have a situation where we have enough bone available. So Nuno has good bone. The density is a very good density bone. You see here, you saw yesterday with Stefan and me the planning. You saw the planning of this case. This is going to be a pure ceramic 2 pieces with transgingival healing. We're going to place a ceramic healing abutment. We are going to use a pilot drilling guide, like I showed you yesterday. We have, remember if you were yesterday there were 4 types of guides that we normally use. In this case, I will pinpoint the best prosthodontic position for the implant. Then I will take out the guide and go manually so you can see the system working. One of the good things about these co-diagnostics software is that it's completely fully integrated with the Straumann system. So it means that whenever I finish planning the case, there you have the PDF, and the PDF goes directly to the local representative, and they send all the material that I need. In this case, you can see that not only the material it's there, but also on the lower one, on number 4, on page number 4, you can see the drilling protocol if I want to go fully digital. Straumann has a surgical kit for the guided surgery that I can show you over here. Meaning that once you have the guide, and this is the guide, if you go and plan a fully digital workflow, meaning that your pilot drilling, your second drill, and your third drill goes into this hole over here, and then the implant goes through this hole. But you can also use this guide only to pinpoint. You can either go both ways. In this case, I will only use the first drill. It's going to be more or less like this. So the drill goes in the middle and pinpoints the exact prosthodontic position. The prosthodontic position of this guide was planned on the software, and so that's the workflow that we are going to do for today. So the first thing that I like to do, like I explained you yesterday, is to check our surgical guide. So the patient is already numb, obviously. And what I like to do is that, wait. Sorry. Okay. So here you see that you have the guide. And like I told you yesterday, I'm a window guy, meaning that if you can take a look in here, you can see that I can see that the central incisors of Nuno are correctly displayed over here. More on the local side, I like these 2 windows over here because I can really check if the tooth is coming out okay and if everything is in perfect position. So the idea is that we are going to do a mid-crestal incision and open the flap, and then I will place the guide and pinpoint the correct position. After that, the drilling protocol, we're going the drilling protocol until the end because the bone is very dense. And then we are going to place the implant. If we feel like you and Frank told, if I feel that I have too much pressure, then we hit it back, make another drilling preparation, and then place the implant. So that's our program for today. Okay.
Great program. So go ahead. We're looking forward.
Great. If you have any questions on the audience also, please feel free, okay? We have the whole day.
I have a question. The sleeve you've seen on the template, so it was a wide one or it was a camera? It's a metal or it's a peak or what is a sleeve in this case with Straumann?
Oh, the sleeve. This is a peak sleeve. This you can have both ways in the Straumann because there's different surgical trays for each implant. In this case, because you're going to use a pilot drilling, it doesn't really matter which type of sleeves are you in. But on the titanium, that's another story. There are different implants. That's not the topic.
But you're working metal free in this case.
Yes. That's why we have the peak there.
If not the implant, but the template. Okay.
Yes. All right. So like you stated, in here, the case is more or less similar as yours. So we go for the mid-crestal incision.
It's not similar, it's just only one implant.
Yeah, only one implant. Then we go for the sulcular one, either mesial and the distal part, so we can have a good retraction.
I see you use the same incision technique like in Switzerland and Portugal.
Yes. It's funny that Liliana mentioned the same. So I think Liliana, she's ready for going to Switzerland.
Yeah. All time invited.
So here you have I don't know if you're seeing, it's okay? Yeah.
Any questions so far from the audience? No. You're doing a great job, they say.
I'm gonna try not to put my arm very much around this area. So you retract the buccal one and then you retract the lingual one. So you can see the bone that is available. I normally like to use this instrument for a flap retraction. Liliana says that this is my best friend. It's my best friend for over almost 20 years. It's very easy. I don't know the brand. I'm sorry, I'm not. And so here you have the bone available. And now we are going for the drilling protocol. So let me explain a little bit the drilling protocol of the Straumann. So Straumann is, if you're used to the tissue level, if you're a tissue level user, you know that it's even numbers. It's 4 millimeters, 6 millimeters on depth, 4, 6, 10, 12, 14, it's like that. But don't forget that this is like the tissue level, meaning that when you have an 8 millimeter implant or a 12 millimeter implant, like in this case, don't forget you still have the 1.8 millimeter of machine color. So it means that you should have careful with your drilling protocol because you only have to drill until that part. So the diameter that you have, it's the first one is 2.2. Then you have the 2.8, that is the yellow one. And then you have the 3.5. And because this is a straight implant, you have the straight burrs. Other implants, for example, have the flute. And to be fairly honest, I have both in my kit because I like the approach of the flute in some cases of hard bone. But the standard protocol is with a parallel flute. Let
me ask you, it's the same protocol for the Straumann bone level titanium implants, the same drills?
Yes, it's the same. It's the same protocol. No. The drilling protocol is different for the bone level. The ceramic pure is the same protocol as the tissue level, implant.
Okay, but you can use the same drills for titanium and ceramic or not?
Yes, you can use the same drills. You can use the same drills.
Same tray.
Yeah, same tray. After you have the parallel drill, then in cases of hard bone, that is the case, you have the possibility of go to a countersink. Okay, so you prepare that crestal bone. In this case, we're going to need it because, as you saw in the X-ray, we have the cortical bone that's very deep. In very dense bones, you also have the tap that you can go and enter manually with the tap. Okay. Once you have your drilling protocol, then you have your insertion tools. On the contrary of Jans, I like to have my motor to place the implants, and then only for the final torque, I use the hand ratchet. I was taught since the beginning like this. I feel very comfortable with that, and I control also the torque. But you're gonna see that the implant has each pure, no matter if it's monotype or it's two pieces, it has their own driver. It's one driver for one implant. You will see. They call mouse jewelry. Okay, so once we are here, the idea is to place this.
How is the fit of the template? It's stable or a little bit wobbling, or?
No, it's stable. This is a tooth guided. I mean, it doesn't have the stability of, for example, a pin, a fixation pin, like I told you yesterday. But obviously, for mandibular reasons, I almost never use a fixation pin except in full mouse cases where we have enough availability. In this case, remember, I don't need that it will be extra stable because I'm not going fully guided. So that means I'm just going to pinpoint and take the guide out. But you see, it's a fairly good retention. But you see, can you do a plan on this? So, but you see that Liliana, I didn't tell her, but Liliana, she's very used to the digital tools because if you can see, the tooth of Liliana is making some pressure on the other side. So we're completely stable. You see? All right.
Oh, it's okay. Does he has a stop, the pilot?
No, I'm just not going full the end because you have here, like I show you in the planning, you have three drills. One has 1 mark, 2 marks, and 3 marks. And the software tells you that you should have the first handle, that it's a 2.2 with the blue dot, and you should have the bigger drill, that is this one. And then you go full depth. Okay, and you will stop on the sleeve like this. I will show you.
That's what I mean. They have a stop, a full stop on the sleeve.
Yes.
Exactly,
This full stop on the sleeve.
Yeah.
Like this. See? It stops here.
Depending on the sleeve position and the spoon height.
Yeah, exactly. It's a combination between all of these things. So place the guide in. Place the 3.
You also are going with 700 RPM?
We are in 800 RPM.
Yeah.
That is the recommended for the first drill in Straumann.
Yeah. I think with the stop, it's really a support, so it makes it quite easy.
Yes, because you finish where the stop is. Now,
exactly.
We go with the retractor, and you see that we have our position. Okay? So we have our prosthodontic position. So now what we are going to do is to place a 12 millimeter implant, okay? So now I will follow this prosthodontic position and do my drilling protocol until 12 millimeters. So if I'm at 12 millimeters, it means that if everything goes okay, then the implant stays with the rough surface on the 12 millimeters, and I will have the 1.8 machined color above that for a supercrestal approach.
But I think it's definitely a big advantage. So if you can use the same instrument like with the titanium implants, and we have the same protocol, nearly the same protocol with the titanium, so you can really I think, I don't know, but it could be the only ceramic implant system which you can use fully guided.
I'm 6, I'm 10, and I'm 12. Okay. I'm a 12 millimeter. Nuno, are you okay? Nuno, okay. So I'm 12 millimeter, and I will check it again with my pin indicator guide. Where am I? And you see, I don't know if you can see it like this, but the Straumann kit is a very useful one because the pins have the number. And so you're always knowing where the depth is. So this, I'm at 12. I'm exactly at 12 where I want to be. So meaning that from now on, you see I have my, my prosthodontic position, that it's done through the guide, okay? It's falling out in the middle. And I have the 12 millimeters that I control the depth, okay? I pinpointed my prosthodontic position, then I went fully depth without the guide. This has an advantage that I like because I like the saline solution to rinse while I'm doing this, especially in these dense bones. So that's an advantage of also doing only the pinpoint part. So the second drill now that we are going to use, it's the 2.8 millimeter burr. It's a straight one. And again, you see here the marks. You have the 4 millimeters, the 6 millimeters, the 8 millimeters, the 10, and the 12. There is no, it's a straight line. So it's very easy for you to see where you are. So you change it. Okay. Okay, I'm at 4, I'm at 6, I'm at 8, I'm at 10. I let the saline solution rinse, and I go until the 12. Okay. So I take out, and I have a different pin, the yellow pin, that's the control pin for, again, for the depths and the position. So I go in and I control my position to see where am I, and I see that I am at 12 millimeters. A little bit there. Again, not 12 millimeters. I'm probably 1 millimeter shy here, as you can see. This is very good with these depth indicators. So in the final drill, I will go that millimeter down to complete the osteotomy. So one of the things that I like to do is ask gently, Nuno, to close a little bit, gently. Face. Okay. To see if I'm pinpointing this on the correct position. Open. Okay. So it points up to the palatal cusp of the upper molar, as you know. So now we go for the 3.5 burr. Okay. In Straumann is always easy to remember the colors because if you're a fan from Porto and you think that the blue is always the first, you already know which burr is the first one. I'm always telling this joke to the patient, at least. Are you from Porto? Nuno is not from Porto, obviously. So I'm going to
Which color you have to start with Benfica?
Your Benfica, Nuno? Sporting? Okay, so Nuno is from Sporting, which is also good. Straumann is green, Nuno is green, everyone is green, so no problem. So the last burr...
Nuno, you're lucky, otherwise he would stop.
So we go again with the 4 millimeter, the 6 millimeter, we go up for the saline solution, 10 millimeters, the 8 millimeters, 10 millimeters, and then we go for the 12 millimeters, okay? Can you stop it? Yes. All right. So after we go for the 12 millimeter, then we check again. We have here the pin, you know, for this 3.5 drilling procedure. And then we go.
How many drills do you have in this protocol?
You have 3 drills. 3 drills. Okay, so you can see that you're on the 12 millimeter position. Okay, so you now, if you want, you can also control it here if you're coming out on the right position. As you can see, you're on the correct position. So you have depths, you have mesial distal, you have buccal lingual position of your implant. So the last thing that I will do here with this preparation is the countersink for the crestal part. Nuno has a crestal part that is very good. So the protocol recommends that you use the countersink, okay? That allows you to prepare the crestal bone. So in this part, I also have the same philosophy as Frank. We go very gently, so almost with no torque, almost with no speed, just for preparing a little bit the crestal part. No, I like irrigation. I like irrigation. I do this with irrigation. I like always to have that part. Obviously, there's a difference, and Frank explained it very well. When Frank is collecting bone, obviously without irrigation, because otherwise the bone is just goes in the saline solution. Okay.
To take out the stress out of the cortical bone, or especially in the tube area, because you don't know really where the tube will end. To go a little bit up with the picture.
Sorry. Yes, exactly.
Much better. Thank you.
All right.
So you open for the neck there.
Okay. So right now I have my implant bed preparation made. It's like this that I prepare almost all the Straumann ceramic, pure ceramic implants. Sometimes if I feel that the bone is not so dense, then I do not do this countersink. And I will try to place the implant directly. I go, and if I have more than 30 newtons torque, then I come down again, do the countersink, and go again. But normally with these kind of preparations, the implant goes and stays very well and sits very well on the preparation level. So now, that's what we're going to do. We have our implant preparation made, okay? And now we have the pure, okay? So the pure comes in a little box like this, okay? All the pure ceramic come in this little box, which has 2 compartments. The one on the right has an individual mounting, okay? Either if it's the 1 piece, the monotype, or the 2 piece, it will come exactly like this. And so the idea is that you have prepared in your slow speed the handling that is common for the majority of the Straumann implants, except the BLX and the TLX. So after you have this mounting will insert in the individual mounting of the ceramic implant, and then the individual mounting picks up the implant, and then goes in. we're going to switch the programs. Okay. So now we open the implant, and this is what we have. Okay. So the first part is to click the mount. Here, you hear the click, and then you take out. This part picks the implant until we rotate a little bit. You feel it's cracking there, okay? So the connection is mounted, and then you take the implant out.
Can you explain us the reason for this procedure, for the individual pickup instrument?
Yeah, I don't know. It's something from the company. I cannot explain why it is. But I think if we had an individual mounting as we have in the other implants, it should be the same. But in this case, the implant is made like this. To be totally honest, I like this. I like this mounting. Well, it's not has the individual mounting, but it has a purpose that in some cases may happen to less experienced hands. And if you see here, this individual mounting has two parts. One part here that is now on this mounting, another part there. So if you go above, I think it's the 75 newtons, it will break here. It indicates to you that you're in a danger zone. So by breaking here, then you take out this from the mounting, and the mounting fits here for you to retrieve the implant. Okay. Obviously, if you go above 75 newtons, you're already in the danger zone anyway. So, but it can happen, and sometimes it can happen, and this is a trick that reminds you of that. Another thing with this individual mounting, but is not exclusive from the Pure, is that you see these dots over here that, first of all, they're coincidentally with the digital protocols, and the second with the prosthodontic components. Normally we tend to leave this on the buccal side. It's not mandatory, but it helps the prosto part. For example, with the scan bodies. If the scan body is turned toward the buccal, your intraoral scanner will be much better. But these are small details that are important, obviously, but not exclusive. Okay. What you're going to see? Aqui, aqui. Okay. All right. You see? Yeah. Let me see if I don't touch your. All right.
It's always fascinating if the white one is going in the red one.
Um bocadinho. Um bocadinho para a Liliana, um bocadinho. Não?
Which torque do you use here?
I'm below 30 still. I'm very light in here in this situation.
Oh, that's fine. It's enough.
Yeah. Then you see, it will stop. Right. Yeah. It stopped below 35, so we're okay. See, and it's seated exactly on the 12 millimeter position of the rust surface, meaning that the 1.8 millimeter that you see here is a supracrestal tissue level color. So I know that you don't have the feeling, but when you feel that the implant is reaching to the implant bed position, you feel a little extra stability. Not enough. We're just above the 35 newtons. People are here can testify. But it all went very, very, very good. So you can then check it if you're, again, wait, it's touching there, the flap. Wait, I'm not in the position. Wait a minute. There's this part. Touching there. Oh. Yes, because the sleeve doesn't allow you to pass over here. But this that is prosthodontically on the correct position. Close a little bit. Close. All right.
Yeah, we can see the right position. This looks really great.
Põe a cabeça bocadinho para baixo. Yes, that. See, it's pinpointing the palatal cusp of the upper molar. So Joao will not have any problem to to restore this one. So open a little bit. So now you take out the mounting part. Okay. And you can see that the soft tissue goes here. Okay. So normally now the prosthodontic procedure, you could have three possibilities. One, it's the closure cap that I showed you yesterday. And the second one is the titanium abutment. And the third one is the one that we are going to use now. It's the ceramic healing abutment. That's for a transgingival approach.
I also love the transgingival approach because you avoid the second surgery, the re-entry for that, and we see all the tissue is coming really nice around peak or ceramic, and mostly we can avoid also the tissue augmentation later.
Yes, so this is the ceramic healing abutment that you see here. It's a two-piece healing abutment, meaning that it has, let me see if I can show it. It's how do you say, a passant screw. I mean, you can unscrew it. And so, sorry, I have big hands for a tiny, tiny screw. Maybe I can show you this. All right. So this is the idea. So I will try to show you with the, normally you can do two things. You can screw it by hand, or you can also screw it with torque. For example, the 5 to 10 millimeters torque with your hand ratchet. I'm going to do right now to see if you can have a better view, or otherwise my fingers will be in the middle and you don't see nothing. Can you see? Can you retract? All right, let me see if I can. See, it almost fitted there. And now, okay. So I don't know if you hear it there, but we hear the 5 Newton centimeter torque. So now you have a ceramic healing abutment over the ceramic implant. So you can see now that the tissue will heal on a full ceramic complex in this case. So this is the pure ceramic in action. If it was the monotype, then like Stefan was telling you, you would have the healing caps for the abutment. But in this case, with the two-piece, is like we do it. Do you have any questions on this drilling procedure, on the implant position, on?
Any question in the audience? You did a great job. No questions, Andre. But honestly, I have to say, if you see your procedure or all the surgeries, however, the question for me could be not why ceramic, so why should we use titanium? So it's the same procedure, the protocols, that all what we learned.
And that's a nice discussion that we were discussing yesterday at dinner. We will probably come out to a place where you just need to choose the implant, and all of the rest, the kits and everything are more or less the same. So that's an advantage, obviously. So
maybe we could do another session, the prosthetic session, so the re-entry after 3 months. Maybe we come again to Lisbon and we'll see the results, and then it should be clear
definitely
to use these kind of implants, or?
Definitely. Well, and if you cannot come here, we can broadcast the procedure also. It's also a possibility.
Yeah, for me, it's always really a great moment, the re-entry or removing the healing cap after 3 months. However, you see a little bit bleeding, Ralph, yes, but it's really fun to see it. And this is my argument, and I think yours also, Andre. This should be the argument to use the ceramic implants.
Yeah. So I'm going for a simple suture, a simple knot on the medial and the distal part. In these cases is more than enough for the tissue to go back again. This was it's a clean procedure, so it will heal nicely. So we've been doing this pure for the last, what, Liliana? For the last 5 years, I think. So Liliana is already a pro in watching the pure ceramic in action. The healing caps, you have several heights. I mean, you have the 2, 3, and 4 millimeter height for these healing abutments. So you can really choose between this variety.
And I think it was also a great case for a beginner to get first time come in touch with this material, with a ceramic implant. And you see, it's quite easy, although the sutures for that clothing, that we are not talking about big tissue augmentations, anything like that. And if you did some of these cases, then you can go step by step forward, and you will have fun.
Yes, I mean, the idea is here is obviously to show the ceramic implant is the main attention. So obviously we chose Nuno. Nuno has obviously a big chunk of bone. Okay, so it would be the case that I would do every day. Unfortunately, it's not always like this, but I also wanted to highlight the procedure instead of the clinical case, which I think is at this point more important. And so here you see that like it was discussed on the other day, yesterday, we don't want to damage the bone. So everything should be low speed, no exaggerated torques. And obviously the last part is the tissue. You should treat very well your tissue. So if you do a clean incision from the beginning and a clear periosteum elevation, then if you use the correct suture material, that is monofilament of Gore-Tex, you will know that Nuno will come here next week, and you will be totally fine with it. Close. The only thing that I normally see with my postgraduate students, and they are here, is that normally they put the healing abutments too high. So you always have to check if you have enough interocclusal space for healing. In this case, we have. Open, close. All right, so I hope you enjoyed the pure procedure from Straumann. This is the clinical protocol. This is a clinic situation. And I'm open to any questions if you have.
First of all, to our patient Nuno, thank you. Yeah! And the second year to Andre. Yay! Woo! Hey, Andre and Nuno, thank you both for this great job, really great performance.
Thank you.
Very,
Thank
very
you.
interesting. And it showed, really, you have not to be afraid to use, to go ahead with that. And Andre, we're looking forward to see you here. But first, the questions in the audience. Ralph, you had a lot of questions? No? That's a good thing for you, Andre. Other ones? No. All done. So I have to say thank you to Andre. Thank you to the team of EID. Okay, there's a question. Okay.
Hi, Doc.
Hello.
It's me, your boy.
Edgar, how are you?
I'm fine. First of all, thank you for this opportunity of being here. It's always a pleasure to be back in Lisbon, and especially spending some quality time with you. It's always a learning experience, and I'm forever grateful for having met you. My question is, in terms of prosthodontic space, there's a little bit of an extrusion of the upper premolar. What are you going to do about it? Is the crown of the lower one going to be like a mini crown, or are you going to prepare the upper one as well, or intrude it with orthodontics?
Obviously. My wife, she's there, and Nuno go for orthodontics. No, Edgar, it's very simple nowadays. I know that in the past we did a lot of cutting teeth and adjust occlusions and so on and so on. But nowadays, orthodontic have advanced a lot, even the comfort for the patient with the aligners. And so these cases of small orthodontic extrusions and malpositioned teeth, it's always an ortho. And Nuno is going for the orthodontic. We had this discussion. And the next question I'll bet you were going to ask, so you do the implant or before the orthodontics? It's not up to me to decide. I only do what I'm told in the clinic. The maestros are the prosthodontists and the orthodontists. And the orthodontists, they do the plan and they tell me, okay, you can do your implant because it will never have an impact on the position of the teeth. And then we go ahead. But in some cases, not in molars, but for example, premolar situations where you have lack of space, normally we do the opposite. Orthodontics first, open the space, and then go for your implant.
Yeah, that would be my approach also.
Yeah.
We will discuss it every evening with Elena, your wife, at the dinner.
Yeah.
Who will be first? There. Okay. Further questions? No. Elena? Okay. Any question else?
What's your name? Artyom asked me how long it takes to intrude the upper one, and I told him that I didn't see the case, but approximately we intrude 1 millimeter per month, and you can just think about it.
That's important information.
Yes.
Thank you, Elena. So you see me here alone with Ralph. You will stay, you come, however. Andre, we see us in a minute. I thank you all for attending this, for me, great and unique event, maybe a little bit historic for Portugal, for Lisbon also. Again, my big thank you to your team, IAD team, to you, Andre, Elena, all the preparation, all what you did, all the efforts. Thank you to our board and to Ralph, the Scientific Advisory Board. It was really a pleasure for me, and especially thank you to you joining us also on this nice day, on Saturday, the 2 days. I think, it was a little bit challenging, but you heard a lot of stuff about ceramic implants. And hopefully try to start, do the first case, and you have here in good contact with Andre. He will support you, I think. I know him in any case. And thank you for coming.
Definitely.
Thank you for coming. Andre, we say bye-bye.
Thank you.
And bye to you. Bye-bye. Bye.
Thank you.
We open the center and close the session. Thank you.